My name is Frederick Marks. I'm an architect and a board member of ANFA. And the session that is about to take place is referred to as Research that Informs Lighting Design in Healthcare Settings. I will be the moderator. Some of you may know who I'm referring to when I mention the phrase, the lady with the lamp. But I would think that all of you will remember the name Florence Nightingale and the contribution that she made in establishing modern nursing in Britain beginning in the 1860s. Now, she claimed that a room with natural light was essential to the health and recovery of patients. And if we think about it, 150 years later, her hypothesis has been proven correct. But I would say that she was probably frustrated as she took her lamp and walked the ward and its support spaces, knowing that there are circumstances when and where natural light would not be able to enter a facility. Well, it's my claim, as of today, that we have the knowledge and we have the means to compensate when there is either an absence or a deficiency in full spectrum light in healthcare interiors. And to support my claim, what I've done is to invite a panel of specialists to talk about the subject at length. Directly to my left is Dr. Sachin Panda with the Salk Institute, who is a specialist in circadian rhythms. To his left is Eve Edelstein, who I believe most of you have met or heard throughout the conference so far. She is a neuroscientist, a clinician with a master's in architecture, and has been a long-term research associate with ANFA. To her left is Dr. Mark Ray, who is a professor of architecture and cognitive sciences at Rensselaer Polytechnic Institute in New York, and also the director of the school's Lighting Research Center. And then finally, Michael White, who joins us from the architectural firm Schuler Shook in Minneapolis, who is a senior lighting designer and an early supporter of the use of evidence-based design. The format that I choose to work this session today is as follows. I'm going to ask each of our panelists to briefly talk about their own professional background. I'm then going to ask them to respond to a series of questions. And then finally, I'm going to ask that you engage in a conversation by thinking about what has been said and posing your own questions. So with that, Dr. Panda.
Okay. Thank you so much for the invitation. I'm Sachin Panda. I'm a faculty here at the Salk Institute. I did my PhD at the Scripps Research Institute right across the road, and then spent 3 years in Novartis doing a postdoctoral fellowship on circadian rhythm in mammals using mouse as a model system. And then I crossed the road again and came over to Salk. And I have been a faculty here for the last 8 years, mostly working on how our daily rhythms, circadian rhythms, help us adapt to changing environment and understanding the molecular mechanism of it. There are two aspects in my research. One is understanding and identifying the light sensors and associated molecules, cells, and circuits that entrain our clock to light-dark cycle, and second, how light-dark cycle and eating, fasting rhythm in turn affect metabolism and disease susceptibility.
And I'm Eve Edelstein, and again, thank you very much for the opportunity to work with ANFA for so many years and to meet you all and to see such a great number of people attending this conference. As Fred mentioned, I'm trying to cross many disciplines and be an interdisciplinary team of one, but very grateful for the many people that I've been able to work with at UC San Diego, where I work with visualization teams and sound engineers, computational specialists to teach at the New School of Architecture, and also to work with practitioners, both clinical and architectural, in order to improve our environments. You'll see later some of the work that we've done, but my inspiration in combining all of these disciplines is to take into account as many of the different neural systems that we have some information on that we can use to inform design.
Again, my name is Mark Ray. Thank you, Frederick, for inviting me here. This is a very stimulating conference and collection of individuals that seem to have a common purpose, which is always bodes well for future effects on the built environment. My background's in sensory biophysics. I was at the national labs in Canada for a decade, mainly working in photometry, colorimetry, that is a measure of light and color. I was the founding director of the Lighting Research Center. It'll be our 25th anniversary next year. What's interesting about this is that the Lighting Research Center has always seen itself as sort of the nexus between neuroscience and architecture. Although I'm biophysics background, the faculty member in architecture, we provide the foundations for Department of Energy's energy standards. We developed the Energy Star test methods for EPA. Federal Aviation Administration is a sponsor. We developed all of their new specifications for lighting using solid state lighting. We have a number of grants from National Institutes of Health, and currently we're working with the U.S. Navy to help them with circadian rhythms on submarines. So it's a very diverse portfolio. Any of you, I don't know if any of you have flown in the Dreamliner yet, 787. We did all the design and engineering of the lighting system on the interior. So we're working about 50 projects at any one time. 95% are funded from outside sources, about 15% from industry, the rest from government. So we have been at that nexus where we're translating, if you will, the neurosciences into lighting standards, lighting applications, and so on. So it's a delight to be here, and indeed honored to share what little we know about how we might impact architecture through neuroscience.
Great. I'm Michael White. I work for a company, Schuler Shook. Thank you, Fred, for bringing me along into this conference. Very glad to be here. I'm an architectural lighting designer, meaning that I work with architects who have a project, and I work with them to try to establish a lighted environment that supports their architecture and does that in a way that is environmentally sound, it's economically viable, and also addresses human factors, creates some visual environment that works well for people. My thinking is that light is an architectural material, and much like the glass and the steel and the rest of the materials, and we need to specify that in a way that a contractor can interpret that and deliver what it is that we imagine and design in advance. Now, what's got me excited these days is the opportunity to add to our list of requirements. We've always sort of known that there was something happening with light and circadian rhythms, but we didn't quite understand what it was or why it was happening, which made it awfully hard to figure out what we should do. And that's changed. And that, to me, is a pretty exciting thing, is to be able to start thinking and start acting in a way that would let us address not only the aesthetics and the economics and the environmental issues, but also to address biology, and hopefully we can light for human health.
Very good. Well, I'm going to challenge the panelists with 3 questions. So the first of that group of 3 goes as follows. What are the risks to human health and performance when there are inadequate interior lighting conditions?
Yes, so I would actually start with a historical background to human evolution. As most of us know, we humans evolved in this rotating planet. For millions of years, we lived in this 12 hours, mostly blue-rich light and 12 hours of darkness. And there was one seminal event that happened 200,000 years ago. We as species learned controlled use of fire and controlled use of lighting. And that defined our human development and civilization later on. And we became the first species on this planet who can get out of our naturally assigned diurnal space and work into the night. And now fast forward, say, up to 50 years ago, another big change happened, and that is the pressure to improve or increase human productivity just to cope with increasing population. So right now, if we look at lighting and how it relates to productivity and wealth, if you want to find the concentration of wealth throughout the world, you just have to look at the nighttime view of the sky. The more lighted an area is, the more wealth is produced there. So this unfortunately comes with a cost, because in the next slide, what you can see is there are 2 panels. On the left side is the nighttime view of the sky of the US, and on the right side is survey of diabetes and obesity by Gallup Healthway poll. And you're looking at population density of adult diabetics normalized to population in every congressional district. And it's not only that, if you look at depression, that also very, very much correlates with lighting, even after normalizing to population. So that brings up one major question. What is happening now is we are spending a majority of population in advanced industrial and developing countries are spending most of their day either indoor, at home, or at work under artificial, non-natural light. And then the social life actually starts after sunset, and we stay awake for another 6 to 8 hours socializing and looking at rectangular pieces of glowing objects. And our kids, when they're born, they're not actually exposed to natural lighting. As Tom pointed out, early light exposure is very important. And our kids are also growing up in very unnatural light. So that has led to what we think the rapid spread of this non-communicable chronic diseases, because this chronic exposure to continuous light, which is unnatural, is putting a lot of stress on our nervous system and neuroendocrine system. And the plasticity built into our nervous and neuroendocrine system is not sufficient enough to handle this stress. So that has raised this idea we have to understand the molecular basis of this light reception and how light modulates behavior and physiology. And if we know which sensors mediate this phenomena, then hopefully we can design the lighting much better. So if I may, can give 3 or 4 slides of the basic research that we do. So we all know that the rod and cones in our human retina, or mouse retina, mediate image-forming vision. We're very familiar with that, and we we have spent a lot of time understanding that phenomena. But we know that human and mice which have lost rod and cones, they can actually do many other visual performances. For example, they can entrain their circadian clock to light-dark cycle. And light can act through the eye and can constrict the pupil. And that was known for almost 80 years. Then light modulates sleep. So in nocturnal animals, light will induce sleep. In diurnal animals, light will cause arousal or wakefulness. And light affects many neuroendocrine functions, and the most popular being melatonin. Light at night will suppress melatonin, and if you go into darkness at night, then melatonin can rise. And there is also another function, light exacerbation of migraine pain. Some people who have migraine, it's very known that migraine is worse if you get into light. And all these responses are removed if you remove the eyes. So that means there must be a novel light receptor in the retina. So almost 10 years ago, we and others found a new light receptor, light sensing molecule called melanopsin, which is present only in 5,000 cells in each human retina, and compare that to millions of rod and cone cells in each human retina. So these 5,000 cells express a protein called melanopsin, which is mostly blue light sensitive. Its sensitivity peaks around 480 nanometer. And these cells, as you can see, which are stamped here, they have very large receptive fields, so which indicated that they may not be involved in image-forming vision. They won't have the spatial resolution. And another interesting thing is they have very large, very long temporal integration. So that means even under dim light, they can integrate light over a long period of time and can signal to various parts of the brain. So finally, what I would like to say is these 5,000 cells are very important and necessary for transmitting light information to the brain, involved in circadian function and various neuroendocrine function. If we specifically kill these 3,000 cells in mouse retina, in an adult mouse retina, then the mouse can see perfectly fine, can do visual discrimination, the image-forming vision is perfectly fine. But it cannot entrain its clock to light-dark cycle. Its melatonin level will be completely misaligned from light-dark cycle, and it will sleep at all random time. So that conclusively, that gave us a very strong molecular handle on this understanding how light affects clock, neurophysiology, and etc. So I think from my perspective, now we have a good understanding of how the system works, and that will help us going back to address some of the non-communicable chronic diseases and hopefully fix circadian rhythms and others. Sorry, it took a long time.
Eve?
Yeah. Well, in addressing the question of risk of inadequate lighting, I feel fortunate that I was able to work in the National Hospital for Neurology and Neurosurgery in London, in Boston at the Mass Eye and Ear Infirmary, and then U.S. Naval Medical Center and a number of other institutes here in San Diego. So I have a chance of leaping from cellular science to how we change the design of the environments in which we provide health care. And I worked with a large number of people on the College of Fellows 2005 to 07 Latrobe Fellowship. And you'll see most of their names there, but not all of their names there. So we did a multi-center study looking at the influence of color on health, and that was the name of our proposal. And after digging into the literature for a good number of actually years, we found that there was a rich and rigorous body of evidence in circadian lighting and a much softer and inconclusive set of evidence in applied color itself. And therefore, that's where our research team went to look at the influence of light on health. So if we could go to the next slide, if I could go to the next slide by pushing this simple button here. What you see is some of the technologies that we used. We measured the environmental exposure of circadian light, working with Michael Ray and Mariana Figura at the Lighting Research Council, using their beta test device, which I'm going to let them talk more about, so that we knew how much light was arriving at the eye and some isolated spectra that are most relative to these circadian receptors. And we also measured the human response by looking at heart rate variability with Julian Thayer and his team, and also looking at our brainwave responses with the team at UCSD. And so our question was, what happened if you have inadequate lighting conditions? Well, having been in a clinic and having worked with architects, I knew that we have to do more than speculate. We have to go in and predict and measure and observe. And the health risk that I found, even before we began the studies, was enormous because we were missing this step of functional analysis of what people actually do in these spaces that we design. So health risk number one, you see the predictive ecotech type 2D plan of where bright spots of light is going to fall in a new emergency department. Health risk number one, light was veiling the glass wall between the emergency staff and their patients, and now they couldn't see the patient's face, and the color of light was going to mask skin color. We could no longer see if blood is perfusing the skin and skin color is changing. We can no longer see the subtleties of chest rising. So just visual accuracy alone, how we light an environment influences health. I then walked through several hospitals wearing the dosimeter and measuring circadian light, measuring photopic light that we usually go around a hospital measuring with our simple meter, and also measuring sound at the same time and using my ethnography to measure behavior. And I found some alarming things that kill people. You see in the very right-hand slide, I worked with some lighting designers who came into an actual environment, and in a distributed medical station where the unusual pharmaceuticals are distributed for an emergency department, not the usual ones stuck by the side of the bed that they always go to. Adrenaline's always in the upper left corner. These are the less usual medications in a room where the instructions for how they should be combined or the bolus amounts were stuck on font 6 on the wall. When I measured the amount of light inside of the medication cupboard and the amount of light on the desktop where they were opening the bottles and distributing the medicines, it was about 20% of what a 20-year-old needed to read accurately. We can save life with a light bulb, but we have to go in and find out where we need to do it. It doesn't take a huge amount of money. It simply takes us stepping into the environment. And so let's look again at the aspects of light or inadequate light that might present a health risk. The upper two left is a neonatal intensive care unit. So we see backlighting here, which we know is an issue for looking at our screens. We also see the bassinet in the upper right-hand picture covered by a blankie. That blankie is in response to literature that suggests that the retina of an infant is susceptible to very bright light. And therefore, they covered the bassinet up with a blanket. But now, the nurse, who might be doing one-to-one nursing or one-to-two nursing, can't see the infant. And they actually argued the babies were more settled, and I asked them how they knew. And they told me that it was for acoustic isolation also, and I looked at the gaps of the blanket and I thought, it's not. And so this was an adaptation, a workaround for a piece of literature that had not been fully interpreted. So again, it's visual acuity, and it's also sightline, where inadequate lighting is impacting our health outcomes. At the lower left is a beautiful oncology suite that doesn't take into account our knowledge of chronopharmacology. That some drugs are more effective if they're administered when cortisol is at its peak, as it is in the morning, to get you to wake up. And so there is a time-related effectiveness of medications that's reported in the literature that we as designers can take into account. And so you see here blue light inserted above these individual stations where patients are meant to receive their medications. And I asked, was this presented to stimulate the circadian system? No, we thought the blue light was a high-tech color that, you know, induced a nice feeling. And so there was no consideration of the evidence in this case. A great effort, including the windows, to give a view to the outside for these patients, but again, not taking into account the literature that exists. And finally, you see a mock-up room of a new patient bed with this fabulous patient bed that can twist all the way around, and they've got a ceiling-mounted head wall, so the patient can twist all the way around. This is for a neuro-intensive care unit, where the chances are that your head is immobilized during your stay. And I'm sure you've all heard of intensive care unit psychosis. And one of the big questions is, how much is lack of circadian light and visual stimuli due to being trapped inside of a hospital room and not seeing natural light or natural activity? So here in this bed, you can, after a procedure is done and when the patient's settled and they're just resting, you can actually twist the bed so they can look out. But I jumped in this bed at this mock-up, and guess what I saw? Fluorescent overhead, and that was in every one of those other pictures. And that's what's typically put into our design. And if I was in that bed with my head immobilized, that is all I would see. And it's very hard to get timers put in so that those lights go off at night, and yet there's enough light in the rest of the room for the clinician to do their job and make sure that you're safe. So there's a few examples of health risks. And we can go on to the next speaker, please.
Let's see. I presume that'll be next. Is that right? Well, we spend a great deal of time dealing with issues of safety, not only in interiors, unless we forgot what the question was, does interior lighting compromise our health and well-being? Standards have been written, even perceptions of safety in parking lots, how much light do you need to feel that it's safe to walk to your car, wide range of those kind of visual studies. But you get a sense now the really exciting piece is on circadian disruption. And what I'd like to maybe give you may appear a subtle nuance, I think is actually a way that I'd like for you to at least to consider this issue of lighting as it relates to health and well-being through the circadian system. What we have here is some published studies that show that circadian disruption can lead to a wide range of maladies. These have also been shown in animal studies where tumor growth can be increased by disrupting a regular 24-hour cycle of light and dark. So dark is just as important as light in this conceptualization of what architectural spaces should do. Now, I think the metaphor that may help you sort of understand a little better how I see the problem, and that is the two girls here, one sitting in the swing and one pushing. Our biological clock has a circadian rhythm in total darkness. So the Chilean miners were going through circadian rhythms in absolute darkness. But the problem is their intrinsic period is slightly longer than 24 hours. So it's on average 24.2 hours. So you can imagine the longer you spend in the darkness, the further you get away from the synchronization to local sunrise and sunset. The girl that's pushing the swing is the sunrise and sunset under normal conditions. She is the one that is going to set the rhythm that you're going to experience. So your intrinsically longer photoperiod gets reset every day when you get up and you see the light in the morning, will reset your clock back to 24 hours. And so it's this relationship between the environment and the genes, if you will, that becomes absolutely essential to mitigating those symptoms you saw in the first slide. So what we're interested in trying to do then, and the real challenge in architecture, is to synchronize. Let's say your child gets up in the morning, wants to go to school, you want them to do well on their SAT scores that weekend. How do you synchronize them so they're going to be perky and awake? Well, you have to manage the light-dark cycle, but it isn't just at school. It isn't just one architectural space, but there's a handoff between architectural spaces, all the way from the time you leave the home till you go to school, you go to the movie, and you come home again. Managing that becomes a real significant challenge if we're going to talk about light as healthy environment. We can do wonderful things in a school, but it all gets erased if they have the wrong kind of light in the evening. Now, what's interesting about that, we've talked about melatonin. This is a slide from Cliff Saper's, I think, very influential publication looking at the neurophysiology that underlies circadian rhythms. So on the lower left corner, you have the retina that feeds into the suprachiasmatic nucleus, which is the site of the master clock. Now, we often talk about melatonin as sort of that primary hormone, but indeed what happens is through the dorsal medial hypothalamus is an integration and a relay station to a wide range of functions that also follow a circadian pattern. Most of us don't drink beer in the morning. We tend to drink beer in the early evening. That is a signal that tells the body what is the appropriate time to eat, what is the appropriate time to sleep, what is the appropriate time for passing that SAT score, or as Eve said, when should you get your chemotherapy. All of those systems are regulated by the light-dark pattern that is mediated by light on the retina, not at the back of the hand. And that's orchestration of not just the master clock, but the communication to all of those other systems, I think, leads to these wide range of disruptions. And each of us has potential cancers or cardiovascular problems that you're going to have. Those will manifest themselves. I should say they're more likely to manifest themselves as you as an individual based upon your genetic history if that circadian pattern becomes disrupted. So I think from an architectural point of view, begin to think about lighting as a personal record every day of where your light and your dark exposure is. And I think the challenge in architecture is if you begin to think about lighting in the context of health and well-being, it isn't just the building you build, but it's a partnership with the other architecture elements that you're going to have to carry that through a full 24-hour pattern. So again, you can do wonderful things in a school, or you can turn off your iPads at night, but it's the whole light-dark pattern of that 24 hours. And as Eve was gracious enough to mention, we are trying to develop technologies now that maintain your history, your daily history of light-dark exposure patterns, so that when you get up the next morning, you know what you should do with regard to maintaining that circadian rhythm.
Michael?
Well, let me begin by noticing that in the question, question talks about risk of insufficient light, and the way that has been interpreted by the first three of our panelists has to do with biology, which this notion to me is relatively new. And I will confess that if the light is insufficient, maybe I'm the one to blame. I have spent most of my adult life devising lighting systems that save energy, and we keep driving to save more and more energy, and we consider that to be virtuous. We're saving the planet, right? But if you go into a LEED platinum building and you leave the well-mannered tour and go back into the cube farm with your light meter, you'll find about 20 foot candles on the desk, mostly from direct systems, and maybe 5 foot candles at the eye. Not very much light. But there are rewards to this risk. We don't really understand all of the risk yet, But what we're responding to, or what we have been responding to, is design for the visual system. And that's because we didn't really understand the rest of the equation in any way that I could use. But you know, that's changing. Now, getting back to a specific part of the question, the risk of insufficient light over the 24 hours, and I think this 24 hours makes a big difference. In my reading through the literature, it concerns me if the intervention is only 2 hours long and we don't know what else happened over the course of the day. The 24-hour period is important to understand. And I think thinking about, you know, the environments where we're going to find this an easily defined a set of risk factors and perhaps easily measured would be in long-term care, where people spend all day inside in low light levels, and perhaps more importantly, at night, they're exposed to light so that there isn't darkness. So we have this low light condition during the day, and then at night, they're exposed to darkness. And part of that has to do with operations. In the state of Minnesota, the rules in nursing homes for incontinent patients are that you must check and change incontinence patients every 2 hours. So they come in every 2 hours and turn the lights on. Now, what lighting fixture is this? It's a 2-lamp fluorescent fixture over the bed, and typically it's cool white, which contains the action spectrum, which is stimulating their circadian system. And this happens for their roommate too, whether or not that roommate is incontinent. You know, if all this is going on next to you, your system is being stimulated too at the wrong time of the day, and not just once but several times. And if you don't need to be changed, the nurse or the staff member will help you get up and take you to the bathroom where they turn on the light. And you spend a few minutes there and you're back in bed and you try to sleep for a couple of hours, but then they wake you up again. So no surprise, even patients who have been sleeping relatively well when they come into the controlled environment after 30, 60, 90 days, they're napping during the day, they're awake during the night, there's no period, and it suggests pretty strongly that the built environment plus the operations side of things is actually making these people sick. So what the challenge is for me is to figure out how we go into that existing situation and design a lighted environment that's going to mediate that. Give them the stimulus when they need to have it, and it needs to be the dose needs to be sufficient. So intensity times duration, it needs to contain the action spectrum, and it's got to be at the right time of day. And when we get to the end of the day, we've got to remove that circadian stimulus for the evening hours, and when it gets to be night, we need to have darkness. Now, the good news is, visual darkness is not the same as circadian darkness. And that's the beauty of having this secondary system with its own receptor that is only responsive in the action spectrum. We can take that out and light for the visual system without stimulating the circadian system, if you know how to manage all the moving parts. And that's where I think I come into the equation.
Great. Which is, I think, a good segue into our next question about what do we do with the information that we've collected. How should the combination of ambient and enhanced lighting be used to accommodate such human variables as age, gender, illness, and activity?
I think we have discussed almost half of this question.
We have.
So I'll begin with the science. So as I mentioned in response to the previous question, we discovered this new molecule melanopsin, and then you would ask, how is melanopsin active throughout our lifespan? Because one part of the question relates to age. So we know our visual system is not fully functional up to a few weeks, a few months after childbirth, whereas melanopsin system is fully active, at least in mice, almost by the second half of pregnancy. So if you take a mouse 5 or 6 days before it's born, in that mouse, the melanopsin system is completely active. And in the newborn mice, even with their eyes closed, because mice are born with their eyes closed, the eyes open only after 10 to 14 days. So in the first 10 days, we know with their eyes closed, the melanopsin system can receive enough light through the closed eyelid if there is sufficient light in the room. When I say sufficient, it's around 1,000 lux. So now let's try to extrapolate that to humans. So we know there are some new studies coming out that newborn babies, even premature babies, many of them do have fully intact and fully functional melanopsin system. So that means if we put a baby in an ICU with 24/7 lighting, we're essentially activating the melanopsin system 24/7, and it will be interesting to go back and test what happens to melatonin rhythm and other things in those infants. So now, among adults, as we are all getting into this era of personalized health, almost every aspect of our health is personalized, or exercise is personalized, or activity, or medicine and everything, personalized genome. But as we know, light affects so much of our health, it's really hard to personalize light. So what we need to do is to go back and learn what is good and bad about spectral composition and irradiance level, and maybe impose that or adapt that into design, which is very similar to personalized air. We cannot personalize air, but we can at least bring the good elements of breathing healthy and use it in architectural design. So I think if I have to design my house again and have full control over lighting design, then I would consider this dynamic lighting. As he pointed out, can we take out certain spectra at night and have sufficient light so that I can write my papers, read abstracts, or do my stuff without sufficiently activating my circadian system so that I can go to sleep with minimum sleep latency. Thank you.
And to take up your point about what happens to newborns who are put into artificially lighted nurseries, I think every mother in the room will tell you exactly what happens as you bring home a baby who doesn't follow normal sleep-wake patterns, and there's scientific literature to support that what all we moms thought was true is actually true also. But if we could have a look at my slides again, please. We asked a couple of questions about how to change lighting in a facility. And there we go. Eve, thanks. Not the movie. Okay. So if we could just, if I could push the button again. Okay, so questions about how to accommodate for long-term illness, let alone aging, and not just our patients, but our staff. Our patients, if they're a mental health patient, such as this facility I have a picture of here, might be 1 or 2 years indoors. This is Toronto area, Canada, so for maybe 7 months of the year, they get 1 or 2 excursions outside. If they are forensic mental health patients, they're even more controlled. They have already committed serious injury to somebody, and so they're mental health patients, and this is where they live. So maybe 1 to 2 years indoors or longer if you're a forensic patient, but if you're a staff member, we're talking about decades indoors. And so we ask questions about how we design for that reality. And what you see here is a mock-up of a room that the designer created, having worked with us to talk about what can we do for circadian lighting. They actually wanted to put a blue panel where you see a yellowish one, and I said, you know, the color of light coming through that, and with the sun setting, you're now presenting blue light into the room. Let's move away from that color. But you see a seat created that's very low level to reduce danger for psychiatric patients so that they can sit and bathe in light. And this was responsive to a very large survey that we did with all of the inpatients and former patients to understand what it is they sought. And they sought spaces indoors to sit. So we actually were able to fracture a 1 million square foot building to bring light into the center, to bring winter light wells into the fattest part of the architecture where there was a great deal of density. But the question is what we do about electrical light, because I can only solve for daylighting when there is daylight. And so this is a study actually inspired again by Mark and his colleagues talking about this concept of light showers. If I present less than 15 minutes of light of different spectra, how does the body respond? Is that enough to give you a boost to your circadian system if you're all day indoors? And so what we did was a controlled experiment with both a bright white light with a peak in the blue spectrum and fluorescent light and darkness, and then what was handed to us is use this as your placebo. It's a red light. And so what we found was what we expected, which was a significant change in heart rate variability during the bright white light with blue. And so as people were doing a memory task, their heart was activating their body, reacting for them to engage in the task. And so you have a lower variability, a greater reactivity to the task. What we didn't expect to see was a highly statistically significant p less than 0.001, I believe, in response to the red light. What happened was the heart remained variable while they were resting, even while the red light was on. But when they had to activate for a memory task, the heart activated even more than it did in the blue light, and then settled back down again. And so I was invited to, after we came up with this data, and by the way, you see a picture of me sitting in front of my computer with this bright white light and blue. This was the night before the Latrobe presentation when we had to give our final results. I'd been flying back and forth from lab to lab collecting the data, and at the last moment we were able to grab the statistics and see we had highly significant results. And so in order to stay up, in order to put all of my data in to present that next day, anecdotally, I can tell you that it works. However, I think one of the first things we should do is work on how we train architecture students, because I started doing this research after 3 years of all-nighters. So we can think about that. But what we see is this highly significant result. And when I looked through the literature, realizing that we hadn't seen this degree of change, and I looked at the existing studies on this red light effect, what you see is it's there, even in the melatonin studies, but to a much lesser effect. What this says to us is we have to look at the gold standard of lighting for the human body. It's the sun. The sun is not represented by one narrow spectrum of light, and it's not even represented by what we call a full spectrum fluorescent light. It changes dynamically in terms of its spectra and intensity. And if we really want to try to understand how to light, then let's light as much as we can and develop our systems so that they emulate what we're designed for. So some very interesting recent studies that are looking to the impact of green light, blue light, the removal of rods and cones, and whether or not some of our circadian systems differ if you remove both the ganglion cells and the rods and cones. So we don't have the end of the story yet, but I argue we have enough to improve our current lighting environments.
Okay, Mark?
Sorry to go back and forth with you. Well, one of the challenges I think that I hope I'm preaching to the choir here among the architects, that is as important, as interesting and exciting as circadian rhythms are, we still need to be able to integrate good lighting for the visual system as well as the circadian system. So if you could, I'm not sure where they are, but so here's actually a case study that we were involved in a few years back, in which on the left is the before and on the right is the after. Now you'll notice some interesting things about even posture, that when you have a dark under cabinet where the professional staff are supposed to work, they actually bring the task out so they can actually see it instead of in the shadow. So we do things like put under cabinet lighting, and you notice how much fuller the workspace is, because it now really becomes a useful workspace. But also, what we're interested in is, if you notice, there's a slight change in the color temperature of the light source. So taking advantage of what we know about the visual system and its brightness response instead of what your light meter reads, you can actually save power, electric energy, by tuning the spectrum to give you a brighter looking atmosphere at lower watts. So the savings here was about 30% reduction in the total watts. Visibility was improved. Perception of the space was improved by Frederick's question about layering light. So instead of trying to do everything with a single light bulb in the center of the room, if you begin to think about what the task is, what the job is, you can begin to strategically apply that. And of course, if you have a higher CCT and a higher luminance, you actually will have a daytime active circadian system as well. Now, one of the things that we've been looking at recently are, and Eve mentioned this in the questions, was the relationship between the vestibular system and the visual system. On the left is a prototype nightlight system. Instead of having the thing you plug into the wall, what it does is it provides you veridical information about the door frame. And Michael mentioned, and it's absolutely true, that under most cases, every 2 hours they flip on a fluorescent light that's over the head. This system is it's been implemented, and I'll show you a picture of it in a minute, but this has been implemented as a night lighting system where the professional staff can come in every 2 hours. You notice it's amber, not circadian active. It provides diffuse illumination and gives you the veridical information about what is that which demonstrates improved balance. And indeed, we've published several papers now showing that rising and postural stability is improved when you have the vertical lines and horizontal lines there. And the reason we know that is because when we deliberately tilt it, they stand up crooked. And you can make them tilt to the left or you can make them tilt to the right. So this is a concept that my colleague Dr. Figueroa has come up with, looking at what I think is important, particularly in Michael's comments about when you are occupying one space all the time, like in senior health care. A 24-hour lighting system is important. Bright, cool light during the daytime, dim, but still providing visual information because you don't want to cause trips and falls, visual information at night. And what you see here are wayfinding tools for night lights, motion sensor activated, that saves energy, demonstrably improves postural stability, and improves the sleep quality. And those are the two biggest problems in senior health care, is trips and falls and sleep. And these lighting systems, we've shown, demonstrably improve both of those measures. So I think as architects, again, preaching to the choir, this integration of visual and circadian in a lighting system and taking the layers of light that Frederick asked, I think is really going to be the key to the next generation of lighting systems.
And Michael.
Well, the question talks about individual differences in age and activity and gender and illness. And in a task ambient system, age and activity are parameters that I would ordinarily include in the regular course of effort to try and design systems that work for individuals. And in some select circumstances, we can do that even in an open office environment if we can create workstation-specific lighting where everybody has their own fixture and they can control it. And that would be ideal, so that you can take, if you need more light, you can ramp it up, and if you need less light, you can ramp it down, and that might also respond to changes in task. doesn't always work the way you might think about it. I've spent way too many hours walking office environments and have seen all sorts of adaptations undertaken by occupants, everything from getting up on your desk and taking the fluorescent tubes out of the fixtures to stapling bed sheets over the fixtures, putting paper clips into the occupancy sensors because they make them crazy because they turn on and off instead of dim up and down. And along that sort of line, I will relate a recent series of events. A major manufacturer of building control systems, they make systems they make controls for mechanical systems and security systems and life safety systems, and they decided to expand into lighting systems, and they built this digital lighting control system. And they installed it in their own facility, in their engineering department, and gave everybody control over the fixture, over their workstation. And the intent was, with this test bed, they'd be able to determine if people were turning them up, they're turning them down, what level do they prefer, and what's the variance between this guy and that guy. Day one, everyone turned off the light fixture over their workstation, and they never turned it back on. They were happy with the perimeter brightness and the light from the screens. Everybody, these are all software engineers, and they've got at least 2 screens. Some of them have 4, and they were perfectly happy with that. So the environments that we think they need may not always be the environments that they want, and it's kind of the law of unintended consequences. Moving on to other parts of this question, just for another second, as regards illness, as a lighting designer, I don't think I'm qualified to address it. I might be able to work with a doctor to address those kinds of things, but in general, the general practice in the office, that's not something that I can directly respond to. I can certainly respond to risk. And I can imagine a situation where I might be able to create an environment that would respond and develop a lighted environment that would deliver therapy. But I think that I need some help, and I should get that help because it's really not my forte.
Great. I'd like to recognize at this time 2 people who are in the audience, Joe Simone and Dan Schaefer, who has joined us from GE Corporation. So in light of their presence and everything that has been said so far, I'm going to field my last question to Mark and Michael, and that is, where would you suggest lighting manufacturers put their focus for the future?
Lighting Research Center. That's not what you meant?
That's your answer.
Well, we work with General Electric a lot at the Lighting Research Center, and I know Michael also specifies a lot of the lighting equipment. And I certainly don't mean this as an unkind comment, because I have huge respect for not only the company but the people. But GE and the major companies, Philips, Osram, and so on, have been traditionally in the socket filling business. They're not really lighting companies. When your light bulb burns out, they give you really high quality light bulbs to put back in. I think that we're seeing solid state lighting now at a turning point where we could actually begin to think about not as light bulbs but lighting systems that are able to be dynamic. They can change spectrum, they can change spectral power distribution. And I know, speaking to the Chief Technical Officer at General Electric, for example, in Hungary, these are the kinds of thoughts that are being kicked around. I think we are potentially at a point where we move from a socket filling business to truly a lighting business at companies like General Electric. I want to remind everyone of the comment I made before, though, that I think the real challenge for the architects right now, if we're going to talk about circadian rhythms, is lighting is no longer something just related to a single building, but it's the life experience as you go from building to building that I think will be the challenge. Our own view is that it's going to be a sensor control system tied to your phone or something like that that monitors that, and then the systems that General Electric builds, for example, can respond to your personal lighting system. And that may not be ambient. It may be something that is Google Glasses or something like that that allows you to manage that. And I think what's clear is this is not folklore. This is really a scientific foundation for regulating circadian rhythms that do have profound impact, not just on health and well-being, but performance and all the things that we've talked about for many years. So I think sensors and controls on a personal platform, I think, is where where I'd like to see the technology go.
And Michael?
What he said. I think that in the largest sense, this is a marketing question, and I'm thinking about marketing as distinct from sales. In sales, I've got a product and I know what it is, and most often my customer knows what it is too, and the question oftentimes is, does he want to get it from me or does he want to get it from somebody else? I might have a novel product and I might bring it to him and sell that to him, but if he doesn't immediately see the value in it, my customer is not going to buy that. Marketing, on the other hand, we need to anticipate what people might want, and we might even create products that no one's ever heard of before. Witness the iPad, and we didn't know we wanted it until we saw it, and that's very good marketing. And I think that's part of the task here, is to figure out what the value proposition is, so that all this good stuff, this good technology, can actually appeal to the people who need to make the decision. And part of this is what Mark was talking about, this new light source. And it inherently allows us to control the light in terms of its intensity and its spectrum, and do it easily, which is really good. And we can certainly control duration and time of day. But there's actually an additional benefit to this system that comes with it if we can take advantage of it. And this is a great example of what we're trying to do here, which is to bang heads together of different disciplines with the idea that we might learn something that would have benefit. A group of guys got fired from an information technology company, and these are network engineers. And they needed a new place to make a living, and they went to look at lighting systems and lighting control systems. And they looked at what was going on, and they essentially said, why are you doing it this way? These things that you're calling LED light fixtures, this is a printed circuit board with electronic components on it and some LEDs stuck on it. This is a computer that makes light. And I've been managing and building networks that control these things for a long time, and I've got a much better way of doing this. I can deliver power and data to each fixture on the same cable, and it's a plug-in device. You're running 277 volts throughout the room, and then every single fixture has a transformer to bring it down to the 24 volts that it wants. Why are you doing it this way? And I've got routers and switches and servers and software that will all control all this stuff already. And it's much easier to install. A technician can install it. You don't need a licensed electrician. It's all plug and play. So that the value there is that it reduces the installation costs. So if we can reduce installation costs, the source itself is inherently efficient, or it has high efficacy, and if it's applied correctly, it can be efficient. And the third part of this equation, I think, is if we can tie that to outcomes. And if we can, and there's the value proposition. I can reduce your first cost, I can reduce your long-term cost, and I can affect the outcomes for both patients and staff. If we can make that a proposal and find the right people that need to listen to this, we might be able to get all the heads to nod at the same time and actually affect this.
We have time for maybe one or two questions, as the mic is going to someone who is willing to raise their hand. Eve wanted to make a comment on the last question.
Could you cue up the little movie clip that I have in my folder? It's the last slide. The question was research directions, and as we're also designers of buildings that are going to deal with both natural light and electrical light and the intersection between, one of the technologies that we can look to is not just simulating where light will be in 2D or desktop emulations, but understand the volume of light, where light sits relative to the individual. So this is just a short clip of the Cal IT2 cave where we're standing inside of, actually it's a virtual model in full scale of Mies van der Rohe's Barcelona Pavilion, and I can manipulate the roof overhang and the dimensions of windows and see exactly where light falls into my space, whether it veils the computer screens, whether or not the patient immobilized in bed gets to, for one moment, touch the warmth of light. It may be the last time in their life that they get to feel the sun, and we can control where that sun is relative to where we need visual accuracy. So in response to Mark's comments, I think you should just send the research funding over to UCSD. Thank you.
That's why you wanted the last one.
It was.
You have a question in the back?
Yeah, I guess the connection between light and the way that we receive light and the kind of effect that has on the body is clear through all of your presentations. And I guess I was just wondering about the ability for each of us to control our own light source. That seems to be brought up as a positive, and I guess I'm wondering if our bodies have an intrinsic understanding of what is a healthy amount of light. Because if that doesn't exist, then I don't know how, like which, Michael, what you mentioned about how the programmers would turn the lights off in the space and just use the light of their computers. Is that a healthy amount, or what's the deal there?
I think it's the difference between what you want and what you need. And we humans aren't always very good at that. I need to exercise. I want to read my book and sit on the deck. And I think that's also true of this group of engineers. They prefer sitting there. Now, what we hope is that those guys get up and go to the commons where there's a big skylight, and they get their dose of light there, and maybe they're okay. We don't really know.
Well, actually, you asked an absolutely essential question. We have no real conscious access of our circadian clock. And that's why you need technology to provide you that feedback, because you have no idea whether you should or you shouldn't get light at a particular time. Those of you who fly to Europe, you're landing in Paris and you open the shades. That's the worst possible thing you can do to minimize your jet lag. But you wouldn't know that. It's Paris. It's wonderful. It's daytime where you should do that. But that's exactly the wrong time to be for doing it. So we believe you need this technology, this control personal device that complements what you're consciously aware of so that you do the right things for light and dark. Excellent question.
Let's close with that. Please thank the panelists.